excited to talk to you today about pediatric stroke. I must say that I talk about pediatric stroke at least 10 to 15 times a year. Can't stop talking about it, love talking about it. I'm glad that you're here to hear about it. We're excited and we're trying to do something a little different today. Today, Susan will be having an interactive discussion with myself and me having an interactive discussion with Susan about pediatric stroke from the neuroradiologist standpoint, as well as the neurointerventional radiologist standpoint, and how we can best take care of our children. We're excited. I think the title is really cool, Different Strokes. That means so many things. Are you ready, Susan?
Yes, finally got to my first slide. Thank you for that.
Let's do it. No worries.
Okay, so yeah, again, thank you for me, and it's so great to see all of you joining from around the world. And thank you especially to SPIN and ASPNR and the other societies and rock stars, Kish and David and Jai for hosting this. So Misha and I were going to talk about pediatric stroke, and we're going to keep it informal and try to keep it fun and share some art along the way. So pediatric stroke imaging and treatment, they've really had a remarkable evolution over the years, and that's sort of going to be a theme throughout this lecture. And this is just an article that I found way back from 1971 that described this young child with bilateral thrombosis of the middle cerebral artery. And back then, they had very limited ways of imaging this challenging diagnosis to begin with. And, as you can see here, they did this arteriogram and unfortunately a post-mortem study which revealed the thrombosis and the infarctions. But we've come a long way, right, Misha?
We sure have. In fact, if you go back and read this paper from 1971, you'll see that maybe, although there's good science there, these people really had no idea what was going on. But fortunately, we have better imaging today and we have better techniques. Because honestly, if I was going to be the person injecting air into the cisterns and then injecting dye and to cut down on vessels, I don't think I would have done this career. Not on a 14-month-old. But today, for instance, we can see that our technology has advanced and things are more savvy. And I would like to say that I think pediatric stroke, the way we do things is so cool that we can be considered sexy. And here we can see that there was a case of a 16-year-old patient who came in more than 24 hours of stroke onset, and we were still able to get the clot out, and the patient did very well. So from looking from back then to today, we're doing big things.
Awesome. So we're going to kick it off with some art. And it's going to be in the spirit of evolution, not just in medicine, but, in the art form as well. And since Misha is also a Greek art enthusiast,
Sure is. Hanging out
so I'm
with
going to be I'll be touching on some of the various art forms and artists in Greece and the evolution of art over the years. So let's start with ceramics. And this was a famous potter named Epictetus. This is his terracotta plate from 520 BC, and it's on display at the Metropolitan Museum of Art. His name actually means newly acquired, which suggests that he was probably a slave that was newly acquired. And his work, he had many pieces, and they were really praised for the fine craftsmanship. At that time, he worked in this type of design called red figure style, where the background of the pottery is actually painted black, and the figures stand in detail with the red clay showing through. That was very popular at that time. And this specific plate shows a boy who's riding a rooster, and his feet are sort of in this unusual sort of position, just rested on the edge of that plate. And it is a reference to the practice of Greek males who would give a rooster as a love gift because it was considered a symbol of virility. So I thought that was really interesting. And then we fast forward to Eleni Vernadaki, and she's actually been called the priestess of Greek pottery. And she's a very revolutionary woman when, women didn't have much of a role in creative voice in Greece. And she created these modern ceramic objects. And she used like these modern elements, but incorporated the ancient figures in her pottery, which I thought was really interesting. And this is from her series called Olympiaka from 2003. It's white ceramic, and these are at the Benaki Museum. And she created this series to be for like an entry for the Olympics that were held in Athens in 2004. So I just thought that was a nice, sort of the new and the old coming through.
Absolutely. So how many people in the audience are thinking they would love to have this in their house? I'm
I would love
envisioning,
those pieces
absolutely.
myself.
I can envision those plates as my setting for a table. And also, how many people got a rooster from their man? I can say that my husband didn't give me a rooster to show me that he had anything going on, but I guess he's a Spaniard, not from Greece. Greece,
Those were
so
the good old days, I guess.
I guess so.
So, anyways, let's go into what is a stroke. So, I'm going to start with just some basics here. It's an acute onset of a neurological sign or symptom that's attributable to focal infarction or to a hemorrhage. The epidemiology is about 3 to 25 per 100,000 children that suffer from a stroke. It's about as common as primary brain tumors, actually. And the incidence is 50-50 ischemic and hemorrhagic, with more hemorrhagic strokes occurring in the younger age groups. Increased incidence in boys versus girls, and Asians and blacks more than whites. There are different subtypes of stroke that we can separate by age in the perinatal period, which is considered up to 1 month, and then childhood, which is from 1 month up to 18 years of age. We can also separate strokes by cause into ischemic strokes, which can be either arterial or they can be venous or they can be hemorrhagic. And Misha and I are going to focus our talk today on childhood arterial ischemic stroke, its diagnosis, and the interventions that we can use. One of the hard things with pediatric stroke is its clinical presentation. It does have signs and symptoms that are similar to adults, like hemiparesis or hemifacial weakness and vision speech disturbances. But the typical presentations in children are actually more common. So these kids with stroke, they can present with a headache or an altered mental status or a seizure. So you may not initially even think about a stroke in a child. The presentation of these kids with stroke can also vary based on the etiology of the stroke. So if it's cardioembolic, typically that's going to be a more abrupt kind of a presentation. If it's an arteriopathy, that'll have a more stuttering type of a course. Moya, children with moya tend to present with TIAs before the stroke. And then posterior circulation strokes can have non-localizing symptoms and can really be challenging for us to diagnose. So all these things can cause a delay in pediatric acute stroke intervention. First and foremost, there seems to be a delay in the consideration of stroke in frontline providers. And I know, we've been, in talking to colleagues, and many of them are like, do children actually stroke, and do they stroke that much? It's really unknown that children actually do stroke, and they stroke frequently. We see multiple strokes every week. There's imaging delays, unfortunately, due to sometimes needing sedation and anesthesia. So we can't get the children in the scanners that promptly. And then, depending on when the child presents and what resources your hospital has, there could be limited staffing and imaging availability, especially when the strokes come in the evenings or on the weekends.
Susan, I'm
So
going to
go
story.
ahead, Misha. Go ahead.
Right. When you go back to that last slide where we talk about frontline providers, there was a young child who was the age of 10 who actually underwent flow diversion due to an iatrogenic injury associated with the right MCA, ICA. And while he was at school, he suddenly started having weakness. And so his teacher sent him to the nurse, which is common when children are not feeling well. And the nurse didn't realize the child was having a stroke, and instead of calling 911, actually called the parents to come pick the child up. And then the child was taken to the hospital. So I encourage everyone who's on this talk or listening to us talk or hearing this recording at some point, try to engage your community in understanding what pediatric stroke looks like and remind them it's truly an emergency.
Yeah, fully agree. And we have some examples of these delays later on in the talk. So, okay. So we all have a stroke alert, and it seems like the adult hospitals really have their act down. You know, a stroke alert is called, everybody's organized, they know what to do, and the picture in the pediatric hospital tends to be a little bit more different. That same sense of urgency doesn't seem to be there. And so we're working really hard to get that urgency into pediatric stroke. And so the development of a stroke program is extremely challenging. And Misha, I know you can speak to this as well. You
Indeed.
know, we need multi-specialty committee that can come together and reach consensus. We have to agree to what the imaging protocol should be based on our resources. We have to be continually educating faculty and staff to the process. And once we try to put the process in place, we have to have regular reviews to enforce the guideline and improve efficiency. I know it's a struggle at CHOA where I practice. And Misha, I don't know what your experience is probably, you know.
Yes, my first stroke protocol that I helped put together was at my prior institution. And now I'm currently at a new hospital. I decided to wear the merch to kind of represent, oh yeah. And so we're working to put our stroke protocol at this new hospital together. And I must say, there are challenges. Out of all these 4 points, the last 2 points, I would say, are the hardest to maintain. Just keeping everyone educated on what stroke looks like, what to do, because it doesn't happen that commonly. And then also having these guidelines and improving efficiency because it's not happening that commonly. You have to keep all your providers who may come across a patient in the hospital having a stroke aware and ready. And so one of the things that we do is simulations, and that has been helpful, but education truly has been the bear of getting our stroke programs and protocols together.
Right. So I'm just going to review the stroke imaging guideline and protocol briefly. So there's two pathways that we can follow in pediatric stroke. One is going down the MR pathway, and the other is going down the CT-CTA pathway. We prefer to go down the MR pathway in children. This is in, you know, it's very different in the adult world where everything's done CT-CTA. In kids, you know, MR will be more specific. It can help us differentiate from mimics, and also we can avoid the radiation concerns. So this is just an example of the acute stroke protocol that we use. I think most institutions have something similar to this. And these sequences are performed in this order. It takes us about 20 minutes, and that's because the ASL sequence that we recently tagged on at the end tends to you know, take a little bit longer. So we start with the diffusion sequence, which can show the presence of an infarct or not right away. And then the second sequence that we always perform will be the SWI. And I love this sequence because it gives you so much information. Here you can see in the right cerebral hemisphere how we have this conspicuity of these cortical veins, and that's because they're in the area of the ischemic penumbra where there's an increase in deoxyhemoglobin. It can really make those veins stand out. So it's sort of like a poor man's perfusion study. You get a sense of what the perfusion deficit is. The other great thing is that it can show us potentially the location of thrombus. Then the next sequence is the flare sequence. And this is really helpful when we combine it with the diffusion imaging to try to time our strokes. So if we have a positive diffusion and a negative flare, then we know that we're pretty early on in the stroke. If we have a positive diffusion and a positive flare, then we know that we're out a little bit further, maybe up to 12 hours for a stroke. And if both are positive and we have onset of edema, then we know that we're approaching that 24-hour time frame. So it can be really hard to time the stroke clinically, but the flare sort of puts us in sort of a time window and can help guide what we're going to do next for this patient. Of course, we're going to do an MRA, which can show us a vascular irregularity, like a focal cerebral arteriopathy or the presence of an LVO. And then lastly, the ASL sequence, which takes some time, but it's actually a super helpful sequence. I try to include it if I can get the child to hold still to that point. But Misha, I know that you love this sequence also because of this very interesting artifact that we can see.
Absolutely. Collaterals are the future of imaging for stroke, in my opinion. And so, although I must admit, and don't tell anyone, Susan, I'm
But
not a huge fan of MRI for stroke. I will say that ASL and in children, this is the way to go. And so I believe that those who are going to benefit from these hyperacute therapies, it depends on their collateral circulation. And that's how we should be predicting whether we should be offering these therapies and whether we should be taking them to the angio suite. So it's a really cool sequence. And I think there's a lot of research that needs to be done on the sequence.
fully agree with that. Okay. Nope. So the other useful thing that the MR protocol can do is to differentiate the common stroke mimics of hemiplegic migraine and post-ictal TODS paralysis. A large number of children that come to the emergency room with stroke-like symptoms will have a stroke mimic. And very quickly, we can make a specific diagnosis. We can rule out a stroke because our diffusion imaging is negative, but the SWI will show us this hemispheric prominence of these cortical veins. So it's a non-territorial asymmetry. MRA can sometimes show us sort of an attenuation of sylvian vessels in the affected hemisphere. And then the ASL really clinches it, showing the decreased perfusion throughout that affected hemisphere from the vasospasm that we can see with hemiplegic migraine and post-ictal paralysis. So this is a really diagnostic appearance for these.
Excellent imaging. Before you move on to the art, one person from the audience, Louise, asked the question, do you include an MRA of the neck with your imaging?
Yes, I do. If I don't have a stroke, I'm not going to spend time on that, right? But if I have a stroke and I will definitely I'll look at the intracranial circulation as part of the stroke protocol, but definitely we'll do an MRA of the neck as well.
So please, to all my neuroradiologists out there, I was about to say to Susan, I don't like her anymore if she wasn't doing an MRA of the neck. Just kidding. But please help us understand what's going on below, because sometimes kids can have dissections of their carotids down in the cervical region. And so we really want to know what's going on with the neck, as well as if we're going to go for thrombectomy, we want to know what we're going to have to navigate in order to move quickly. So yes, keep an MRA neck in your protocol. Susan, I'm coming to CHOA next.
Okay, onwards to sculpture. And so this is one of my favorite statues in Greece. It's the Hermes with the infant Dionysus. It was created in 4th century BC by a famous sculptor of that time named Praxiteles. And if you go to Greece and you visit ancient Olympia, you'll be able to see this phenomenal statue. It was made out of a single block of marble that was brought from the island of Paros, which is a really fun and cool island. And the marble that comes from that island is actually known for its purity and its luster. If polished, it almost gives like a flesh-like appearance to the statues. And
Beautiful.
Praxiteles actually created his sculptures with some movement, and you can see this sort of S-shaped configuration of the sculpture as it stands, and that was called the Praxitelian curve, and it was adopted by sculptors at that time. And it sort of has a very dreamy quality. Its face and its torso are very highly polished. And it was found back in 1877 by a German archaeologist who was excavating the site of ancient Olympia, and it was buried in the rubble from a previous earthquake and was pretty well preserved, except you can see there's some missing forearms. There was a missing foot, and of course, the penis is always missing in these statues. So it really is a beautiful work of art, and I encourage you to go see it if you're visiting Greece.
Okay, Susan, when are we going to go?
Just tell me, I'll tell you where to go. So and now I'm going to fast forward to recent day, the famous sculptor Costas Varoutsos. He has many sculptures in urban spaces around the world, including the United States. And this sculpture, which is called The Runner, he created in 1988, and it is in Athens, so you might be driving by it. It's made by thousands of pieces of glass that were stacked on top of each other to create this blurred shape of a runner. And so his sculpture really, it sort of gives you this sense of urgency and rapid pace, which is so characteristic of our modern time and really is in juxtaposition with the very relaxed state of the sculptures back in ancient Greece. I guess those were the good old days, right?
Indeed, indeed.
Yeah.
So
Okay. So go ahead, Misha. Do you want to say something?
I was gonna say, just like we saw that sculpture running, I want to remind everyone, whenever we're dealing with stroke, we are running, okay?
Yes.
Sitting in the chair, reading the images, just run in your mind. But now we're going to actually run on into the angio suite. So we're going to start with a few cases, and we're going to talk about the concepts of offering the hyperacute therapy of thrombectomy. Remember, there are two hyperacute therapies that we can offer to our children presenting with stroke. One is TPA within a 4.5 hour window, and one is thrombectomy, which the clinical trials suggest up to 24 hours. But as we first discussed, we saw that kids may be able to go a little longer with their symptoms because of great collaterals and get thrombectomy later. So I'll never forget this case. This was a case of a 16-year-old boy with asthma. He was found in his bedroom in the morning. The last known well was when he went out with friends, came back home. He said goodnight to his mom and he went upstairs to bed. And that was probably about 9:30 p.m. that night. Next morning, when mom was trying to get him up and out of bed, she was calling him. He wasn't coming downstairs. So she went to investigate what was taking her son so long. She found him in his bed, nonverbal, not able to really sit up, definitely not able to get out of bed. And he wasn't moving his right side. She immediately got him into the car, drove to the nearest hospital. They did a CAT scan. And interestingly enough, this is the CAT scan performed at the outside hospital, and it was read as totally normal. But everyone, every time, regardless of the history that you're given, please throw on your stroke window, because as you can see, we're losing that gray-white differentiation and the left basal ganglia region and the territory of the MCA. And so when we got our CTA, this patient was transferred from outside hospital. We got a CTA, and we noted that there was an abnormality of the left terminus with filling of the ACA and MCA. Now, when we talk about large vessel occlusions are exactly what they sound like. It's going to be thrombus and a large vessel, and it has to be completely occluded. But given the fact that this patient was having such severe symptoms, he was right-handed, this was a left-sided deficit, we knew that he had a pediatric NIH stroke scale of 23. We knew that this would be devastating for him. And although we didn't see many changes on the CT head, we knew that if his collaterals gave out, this would be a large territory, left MCA stroke in a 16-year-old boy. So we ran on over to the angio suite, and here we have a classic appearance of a string sign, and we have a dissection. And so there's a lot of debate amongst pediatric neurointerventionalists, knowing that arteropathy is going to be a common cause of pediatric stroke in the pediatric population. Do you touch it? If you touch it, will you make it worse? Well, what I did in this scenario was I actually pulled up an aspiration catheter and just tried to vacuum out the clot. And was successful with one pass, one vacuum, and here's the clot we actually were able to obtain from this dissection. And so when I saw this patient in follow-up, he actually, with his 16-year-old self, gave me a hug. And the first words out of his mouth when he finally remembered meeting me, because I did see him at bedside, but he wasn't too with it, was, "Thank you, Dr. Martinez. You saved my life." He ended up with an MRS2 outcome, which means just a slight disability. He remained a little weak on his right side, but we hugged, and I, as you can see with my mask on, because this is around COVID time, was just absolutely thrilled that we were able to change this young man's life. Moving on to case number 2. Now, this is a different type of scenario. Here we have a slightly younger child. We have congenital mitral valve disease in his history. And we can see that children don't have the same reasons and etiologies of stroke like adults do. The first kid, he was believed to have some type of connective tissue disorder, and this kid has known cardiac disease. And I would say that's the two major histories that we're going to get when we're dealing with these strokes. And so here you can see we're losing that gray-white differentiation in the MCA territory. And on CTA, we have an abrupt occlusion of the proximal M1 segment of the right MCA. And so we took this patient to the angio suite, and we tried and we tried and we tried again, okay, 3 times, because we can't do a lot. And pediatric vessels, they're a little bit more fragile than adult vessels, and we could not get the clot out. And so subsequently, after leaving the interventional suite, we saw progression of that MCA territory infarct. We saw the dense MCA sign indicating that the thrombus was still there. And then subsequently, patient underwent a hemicraniectomy due to malignant edema. So what can we learn from this case? Well, our devices are doing pretty good, but they don't always do well when it comes to certain types of clots. So the clots that we love are going to be the clots made of red blood cells and platelets. But the clots that we hate with a passion that burns deep in our soul are fibrous and calcific clots. And so likely this was a fibrous clot. They're sticky. They like to adhere to the vessel wall. You can start doing damage to the actual vessel as you're trying to remove it. And in our pediatric population, we don't do a lot of passes, meaning put the stent in, try to take the clot out, it doesn't come out, go back again, put the stent in, try to pull the clot out, because we know with research that there's a lot of intimal damage with these devices. And with our fibrous clots, we're not going to just be able to go up and vacuum like I did in the first case. We actually have to get our stent retriever out, which we'll see in our next case. And so our next case, you can see that there's similarities, but there's also differences. This is a 15-year-old, so automatically think larger vessels, pretty much adult size, whereas our prior patient was 6 years old, so think smaller vessels and more fragility. But this 15-year-old presented with a sudden onset of right-sided weakness and aphasia. He has a history of cardiac disease as well. When we look at our CT, it's not as subtle as the very, very first case with the dissection, but we can see loss of gray white differentiation in the insula and the putamen. When we look at our lower cuts, we can see in the sylvian fissure, we have a hyperdense left MCA sign. When we look at our CTA 3D reconstruction, which I'm going to take a pause to add a teaching point here. Whenever looking at vessels, whenever, however, wherever, please, please, please do a 3D, because you're not really getting the full concept of what that vessel is doing on 2D images alone. So make it your practice, whether it's MR, whether it's CT, to do a 3D vessel reconstruction. And so here we can see a cutoff of the left M1 segment at the left MCA. And so this is what a stent retriever looks like. You can see that this patient has a tiny microcatheter. There's no larger bore catheter to suggest that they did any suction, but this stent, it goes out into the vessel, intercalates into the clot, and then the idea is you pull it back and it's going to grasp all the clot. The concern is not to send little emboli flying distally, which you can't go after, and can cause pretty significant neurological defects. But here, with one pass or how many passes it took, we can see that post-thrombectomy angio, we have filling of our vessel tree. So as we talk about art and the importance of art, for me, this is my art. That picture before and this picture after is absolutely beautiful. I could stare at these vessels for days and days and days. Okay, I digress. Sorry. Sorry, Susan. Beat it
No,
up.
that's okay.
All right.
And just kudos that like this was the neurointerventional team at Emory.
Yeah,
And I wanted to show this because it's such a beautiful example of what we can accomplish if we can
absolutely.
get our act together. And in this case, the the door to needle time was about 3.5 hours. So everybody was right on it, and we got this great result.
Amazing. And so I think there's one more case, and this is our controversial case. This is a 2-month-old with seizure and decreased left-sided movement. We can see there's a large right MCA territory infarction. We can see that there's thrombus in the right M1 segment, and we can see that there's abrupt occlusion on time of flight imaging. Now, the question is, with a patient this age, are we going to the angio suite? In this scenario, we did not. But I will say that based on literature, based on what we're doing in pediatrics, there's a lot of discussion, and every child should be assessed on a case-by-case basis.
So on this case, Misha, is this a case that you'd go after with the thrombectomy, or like what would you consider? It's a large, very large infarct, and there's a clear clot there.
There is. So this meets criteria for newer criteria today. A study done last year, 2023, shows that large territory completed infarctions actually benefit from thrombectomy when there's a large vessel occlusion instead of standard medical management. But remember, this is data on adult patients and not in the pediatric population. So we're not necessarily applying these rules, but we're still assessing on a case-by-case basis. Number two, we also have to realize that 1/3 of patients will actually reverse their DWI abnormal signal intensity. So this actually can be an overestimation of what's going on, because a recent study just done this year showed that even patients who are 80 years old and above who had an acute ischemic stroke, they also can reverse their DWI signal. So the common teaching is that when we have DWI intensity, this is an example of a completed infarct, but this is not actually the case. And so what can we do to kind of finagle all of this and make great decisions? Well, it's all back to those collaterals, y'all. We need to understand what's going on with each patient because not all collaterals are created equal.
Okay, so just as a recap, so when is endovascular thrombectomy an option with acute ischemic stroke?
We like to go by the strict rules from the 2015 trials that we call the Big Five. That's going to be no blood that's causing the symptoms, not too much territory infarcted, and there has to be a large vessel occlusion. Now, the definition of large vessel occlusion based on the stroke trials is M1 and terminus ICA. The posterior fossa basilar was not included, but because occlusion of the basilar is pretty much not compatible with life, we'll go after those two. So large vessel occlusion, not too much infarcted brain, and no blood on the imaging causing the symptoms.
Okay, onwards. Just a second. Okay, so we're going to get into painting now. So, yes, I love this art stuff. These are the ladies in blue, and this is a fresco from 1600 to 1450 BC. It came from the Palace of Knossos. If any of you have gone to Crete, you should absolutely visit it. It's amazing. And it's this fresco is in the Archaeological Museum. And it shows these three women that are very richly dressed with these blue low-cut dresses with their breasts exposed. And they have a lot of jewels, and they're wearing the modern hairstyle of the time, which was the equivalent of the modern day ponytail. And the ancient Minoans that were on the island of Crete created this type of painting on wet plaster, where the pigments that they use would actually seep into the plaster, and that's why the colors are so well preserved so many years afterwards. And then rapid forward to Alekos Phasianos, who was a very famous Greek painter. He is referred to as the Picasso of Greece, and his artworks have been exhibited in museums around the world and in Greece. And he has this expressionist style where his images are very 2D, the colors are very solid, the faces are usually in profile, and you can see the very strong ancient Greek features. Um, he combines, ancient myth with modern situations of Greece, and his paintings always have a component of motion in them. As you can see, the hair sort of looks like it's flapping in the breeze or an article of clothing. So his paintings really feature that. And this particular painting is called Phryne with Birds. And Phryne was a prostitute in ancient Greece in 370 BC. Back then, prostitutes were actually very wealthy and very educated women. And they took Phryne to court because they felt that she was ungodly. But she was making her case, and then she exposed her breasts, and the jury acquitted her of all crimes. So that was Phryne's story.
Deep. You took us deep.
If we could just expose our breath. Okay, onwards to more stroke. So this is a 15-year-old with dizziness. And what we can see here on the T2 is these focal signal abnormalities in the pons, no evidence of diffusion restriction or evidence of hemorrhage on susceptibility weighted imaging. So these look like little lacunar infarcts. And I read this just, it was a random day, and it came across with not a very interesting history, but this finding really raised concern about having to do more imaging to see if the posterior circulation was intact in this patient. So we went on to MRA, and here you can see that we have really good flow-related signal in the anterior circulation, but the posterior circulation really looks very tenuous. The distal vertebral arteries are not well seen, the basilar artery. If we look into the neck, you can see that the proximal verts actually have good flow signal within them, but we start losing the signal at the V3, V4 segment of the vertebral arteries. So of course, there's a lot of flow-related signal dropout that you can have with MRA, and the more specific study to do for complete evaluation is to go to a CTA, which is what we did. And on the CTA, we had good filling of the vertebral arteries, like you can see here in this coronal reformat. But it looked like there was a little filling defect or something in that basilar artery. We did the 3D reformats like Misha said, but because this was done by the technologist, it's not super helpful. The 3Ds have to be a little bit more higher resolution. But anyways, based on these findings, this patient went to angiography, where they saw this filling defect in the distal basilar artery and called it the thrombus secondary to a dissection in the region of the basilar artery, which, we thought it was a little bit unusual location for a dissection, unusual location for a vasculopathy. It just didn't really make sense. So we went and, sorry, I think I lost there it is. Oh, darn. Are you guys seeing my screen?
Yeah, I see your screen. It's not showing presentation mode. So
It's not?
No, it's not a presentation.
I don't know what happened. Just a second.
Oh, sure. But we have been getting questions
Oh,
from
there
the
it is. Do you see
audience.
it now?
We're back. Yes.
Okay, perfect. Sorry about that. So anyways, we went back and we sort of reevaluated the case and did a really high resolution 3D. So this is sort of what we want to do. And you can see in the right vertebral artery, just as it's emerging from that right transverse foramen, the presence of a small dissecting aneurysm. So when we go back and we carefully scrutinize that angio, you can see at the very bottom of the film, that's where that dissecting aneurysm was, which was where the clot originated from and embolized into the basilar artery. So we need to be really, really deliberate and thorough in these investigations, because vertebral artery dissection and thrombosis is a real thing in children. Older children with CCJ anomalies or trivial trauma can have these types of injuries because the vertebral artery is exposed in that V3 segment. These posterior circulation strokes can have a nonspecific presentation, and we may not recognize them right away. And this is really beautiful work that one of my colleagues, Steve Little, does. He does these beautiful reconstructions, and they published this great paper in conjunction with Vanderbilt Children's. And I recommend you guys take a look at it. It's really great work.
It is a great paper. In fact, before you go on to your wonderful art that I am now truly an enthusiast of, I came up with a way for us to remember bow hunter syndrome. Okay, so bow hunter syndrome, which I suspect this patient might have had, is going to happen at the lateral process of C2 or above. And so if it's at C2, think bow hunters, boo-boo. You guys like
Right,
that?
right. Bow hunters. Just remember posterior circulation strokes. They are not uncommon in
Absolutely.
kids.
Absolutely.
Um,
Bow hunters.
So, okay, on to the Parthenon. We can't talk about architecture without talking about the Parthenon. It was built in 438 BC in the Doric style, which is a very simple, sturdy column with a very simple capital. And the architects were Iktinos and Kallikratis. And the estimated cost of building a structure like the Parthenon today is equivalent to $7 million. So it was quite an undertaking at that time. It's interesting that all of the columns of the Parthenon actually are slightly tilted inwards, and that's to give an optical illusion from a distance of perfect symmetry and straight columns. So their engineering really was brilliant for that time, and helped the Parthenon withstand a host of earthquakes and ravages. And I just found it really interesting what this poor structure has gone through. So it was initially built to worship the goddess Athena, after which Athens, Greece is named. But when the Byzantines took over, they converted the Parthenon to a Christian church. And after that, when the Ottomans took over, they converted the Parthenon into a mosque. And then later, the Ottomans actually stored their gunpowder inside of the Parthenon. So when there was a war with the Venetians and they launched a cannonball into the Parthenon, the gunpowder exploded and caused massive structural damage. Then there was, the Greek War of Independence with the occupying forces, and they would take the columns apart, and they would use the center iron core that was held there to hold those columns together, and they would make bullets out of them. So there was further damage from that. And then the Parthenon just sort of lay in ruins, and was open to the elements and to looters. And Lord Elgin of England actually went and took some of the friezes and the sculptures from the Parthenon and shipped them to London, England, where they're on display at the British Museum. And the Greek government has requested their return. So we'll see what happens with all that. But fast forward to modern day Greek architects, Alexandros Tombazis and George Batsios, who are proponents of this style of architecture called brutalism, where the structure is at its basic element, concrete and simplicity again. Simplicity sort of in a similar way that the Parthenon was built in that simplistic way. So this is a great example of brutalism architecture. And if you're in Athens, go take a look at this building. So.
And also tell this guy to come build my future house.
I know, it's beautiful.
Can't wait.
Okay, so onwards now to 15-year-old with 1.5 year of migraine-like episodes presented with a right facial droop weakness, dysarthria, in a very high pediatric NIH stroke scale, presented to an outside hospital where the stroke was not initially appreciated, and then came to us for further imaging. And we can see on the MRI that we have this acute stroke in the region of the basal ganglia, with the corresponding flare and diffusion restriction, and also some foci of diffusion restriction further out, suggesting that there's some sort of an embolic component going on here. We did our perfusion imaging, which shows the decreased perfusion in that left cerebral hemisphere. So there's a big diffusion perfusion mismatch. Okay, and also the underperfusion of the contralateral right cerebellar hemisphere, which is the phenomenon of cross-cerebellar dieschesis, where there can be decreased perfusion and metabolism in the contralateral cerebellum when we have a large supratentorial, typically stroke. And then our susceptibility weighted imaging actually shows a thrombus in that left middle cerebral artery. We did an MRA, and we have some narrowing and irregularity of the internal carotid artery in an appearance that's very characteristic for FCA. And we also did vessel wall imaging, and you can see the enhancement of the vessel wall here. And the patient did not go on to any intervention because of the delayed presentation, but also because of the history, the unusual history and the findings that look like FCA was present and the presence of thrombus. So they chose not to go after this. And I mean, that is a point of discussion, I think, about, if you don't have an LVO, but you have a thrombus in FCA, do you go after those?
It's a case-by-case basis. We have very strict criteria based on our randomized controlled trials on what we should be going after and what we should not. And so large vessel occlusion, as we define, is really truly M1 and ICA, distal ICA. When we start going after things that are not completely occlusive, like we have partially occlusive clot, or we have a dissection like in the very first case, we're in a gray area. And so medical legally, we have to be aware that when we're choosing these patients to take them to angio suite, there are risks associated with these procedures that could be catastrophic and cause death. And so in our pediatric population, where we don't have any level 1 evidence, we really want to be careful about what we pursue and not pursue. And so in this situation, I would not have taken this patient to the angio suite because there's not a large vessel occlusion. I do see image findings of FCA, and I would prefer medical management in this scenario.
Okay, well, then we'll go on to this next case of a 5-year-old who was previously healthy, started kindergarten 2 weeks ago, cough, runny nose for about a week, 24 hours of vomiting, abdominal pain. A lot of these weird symptoms, you don't necessarily equate those with a stroke. And he presented finally with a dysarthria. When he came to CT, we can already see the loss of the gray-white differentiation, significant hypodensity in that left temporal lobe, and the presence of this dense MCA sign. We moved on to MRI evaluation, and we can see the diffusion restriction in that left MCA territory with corresponding decreased perfusion and corresponding flare signal abnormality. So everything is corresponding here. We don't have that mismatch of diffusion perfusion, and this is considered a complete stroke. On SWI, we can see the thrombus that's present, and then the characteristic irregularity of that ICA and M1. So the whole presentation, the fact, that, we see this is very consistent with FCA. We did vessel wall imaging in this case as well, and you can see the enhancement of the vessel wall. No intervention other than steroids and anticoagulation were used for this child. Even though we saw thrombus, it was non-occlusive, and did not go after it. So this is just to the point that you made earlier.
Absolutely.
Okay, so let's recap. Imaging and management of focal cerebral arteriopathy and AIS, very different from the LVO scenario, right, Misha?
Absolutely. And
Yeah.
for all my neurointerventionalists out there or future neurointerventionalists, be well aware of the causes of stroke in children. Again, assess each child on a case-by-case basis, and then always think about keeping that child safe in the end.
Okay. And this brings me to the end. We're going to talk about music. This is the Smyrna Trio, who were very famous in 1932. They were a Greek rembetiko band. Rembetiko music was a very type of popular music back in the 1930s. It was the music of the working class that frequented like these underground establishments. It was associated with like this subculture. And the lyrics of the music really featured like social issues, protests, social injustice, persecution, unemployment, all these things. And then fast forward to today, and you heard some of his music in the very beginning. Black Morris, one of my favorite artists, he's a Greek rap artist, and he's been called one of the most influential up and coming rappers in recent years. Frequently, when he steps out on stage, he steps out to the music of Rembetiko with those sort of same themes in his lyrics. And he reflects on his experiences as growing up Black in modern Greece. I grew up in Greece, and when I was young, Greece was a very, very homogeneous white Christian society. Over the years, it has really increased in its diversity, and that's reflected in its population and its music now. And so he's dressed here in the uniform of a tsolya, which is the ceremonial military uniform of the Greek Presidential Guard. So I thought that was really interesting, and I hope you enjoyed the art that I shared with you. And then just like a couple of take-home, very simple, always keep acute ischemic stroke in mind and have an acute stroke imaging and management guideline in place. And I think
Now
that
play
ends
the
our
music.
presentation. Thank you so
Now play
much.
the music while we do the quiz. Let's go. Thanks for listening, guys.
Thank you.
That was incredible, and I think the discourse, the conversations that flowed, is what real world is. This is exactly the kind of conversations people need to have a lot more in real time. Thank you very much, Susan and Misha. It's not just about the content, it's about delivery, it's about how to communicate with each other. And I think though you guys are geographically so separated out, and I know this was put together in the last minute, I think you made it flow beautifully.
Kish, you're not supposed to tell our secrets about the last minute stuff. What do you mean?
David will agree. So we're going to kind of keep the audience at the moment because a lot of them are here to win some prizes. If you guys want to take some of the questions in the background